So good afternoon, everybody, and thank you for joining us today in the Northwest Clinical Leaders Network session. For those of you who joined us at the last session in November, we tend to have these sessions every 3 months, or at least 3 times a year to 4 times a year. You probably would have joined Rob Webster and Claire Fuller, who gave us a broad overview and an outline in relation to the integration agenda and where we as clinicians and clinical leaders can support that process. And this session is part of a series of sessions for leaders from across the Northwest, certainly for this particular session is just for the Northwest region, how we can work together and support each other in delivering the integration agenda. I'm Raj Kumar. I'm a GP in my day job. I'm also one of the national clinical directors for in NHS England for clinical informatics. So part of Tim Ferris's team, and the NHS Clinical Leaders Network was something that myself and Dr. Coley had established over about 15 years ago. So I'm really pleased that we're continuing to be able to support the network of clinical leadership from across different parts of the country, but the Northwest is a particularly active area. We have, quite similar to other sessions that we hold, we have an exciting list of speakers who joined us today. And they're all going to be talking about reducing health inequalities and improving life expectancies, and the potential of what integrating care can actually bring about in terms of producing change. The central themes are all about transformation. In fact, Tim Ferris's directorate, and I do one small area of his work, which is informatics, and it used to be called NHS Digital before, but it was all about transformation, and the Transformation Directorate is one of the largest directorates at the centre, and transformation is all encompassing, and integration is really, really high on the agenda, because and often I think we're putting down all the solutions to problems that we're facing currently. We're painting a picture that when we do eventually integrate, we should be able to do away with lots of these problems. But I suspect that we will come across more challenges in trying to take forward the integration process itself. And we as clinicians and senior managers, all that we can do is continue to work with each other, ensure that we understand what the challenges are, ensure that we're aware that people sitting across the table or virtually actually do face the same challenges that you do in your workplace. And during this process, I know the pandemic is settling down now. I'm hoping that Andy and Susie would be able to get some face-to-face sessions also, where we can meet up face-to-face in future meetings, and probably be able to have a cup of coffee or even a meal afterwards. So without much of a further ado, I'm going to hand across to Dr. Andrew Coley to take you through the agenda today, and to Susie, and enjoy the afternoon. And as I said, you're here to interact, you're here to network, so ask all the questions that you need to. If they can't be answered during the session, you will receive answers afterwards. And after the session, by all means, continue interacting with fellow attendees and so on, and you can do that through Dawn. And I hope you enjoy the day. So thank you again for joining us today. Andy.
Thanks, Raj. That's really good of you to introduce us, and welcome everybody, and thanks for joining us. You know, this is the second of the 3 sessions that we're running for this financial year around integrated care and the leadership of that. And as you know, probably the CLN has a long history of leadership, of clinical and care leadership, really, about bringing transformational change and taking forward programmes of improvement generally. And we have a very, very strong push that we recognise that the leadership is a disseminated leadership through the whole system. People that work at all different types of levels are leaders in their own right, and their influence on both the people they work with and the network that they engage with is the way that the good messages begin to spread and how you begin to get significant transformational change. And I think if you do it in the right kind of way, where the subjects are fully discussed and considered, you begin to get a belief and a buy-in that really brings about the change process more effectively and makes it much more sustainable. And that is something that we strongly push, rather than it necessarily being a sort of top-down driven, this is the new approach and how it should work. It's more about getting underneath it with all of us as colleagues, forgetting our organisations for a moment, forgetting our particular areas, and learning and sharing with one another about the kind of issues that we have, the blocks, the opportunities, and why we're trying to do this particular piece of work. So this, in essence, is about that. And it's about that integrated care piece, which we all know has been really important for many, many, many years, and it isn't just recent, particularly in health, social care, and of course voluntary sector type people, and how the integrated working can give a much better service for the patient, the client, the citizen, whatever you want to call them, and depends obviously which arena you're working in. Now, this event was supposed to happen in January. But obviously we had the issues about the strikes and things like that. So we polled all the members, and we got a very strong message that at that point they didn't feel like they wanted to hold a session in January. So we've delayed it until now. But I'm hoping that this is going to be a really good one. The first one was very much more strategic with Rob Webston and Claire Fuller, the bigger picture stuff, you know, that what's going on. But now we're drilling down into a subject area in terms of cardiovascular disease and what that might really look like in the real situation, and also a real place in terms of Sarah Jane, one of our directors from the Lancashire region, and what's going on actually deep down in their place, and what it is that the key issues that they see about trying to get something effective from this integrated care in a system that's incredibly busy, incredibly pressured, very short financial situation. So a long ask, but yet we're going to try and explore why this integrated care approach could significantly be important to deliver better care in a more cost-effective way, hopefully, as well. Now, what I'm going to do, I'm trying to stick to time. So we've got this, if you were here last time, we've got this piece of software called Menti, which is really useful because we can use it for feedback, live feedback as we're going through the session, feedback for the speakers so they see it as we're talking and they're giving their talks. And we can also run some questionnaires on it in the middle of the process, which gives us all immediate feeling of where we are, what we're thinking. Because, of course, when we've got 30 or 40 or 50 of us online, we can't all talk at the same time. So it's a great way of getting some communication in. And I'm going to introduce Susie Ning now, who's our National Operations Director in the CLN, to introduce Menti and also pick up on anything that I've just missed. Thanks, Susie.
Thanks, Andy. Thanks, Raj. Just a very quick brief on just some general housekeeping. We're going to obviously recording the session today, and we'll make that available on our YouTube and also on our NHS Futures platform as well. So I'll pop the link at some point in today's session if you want to access that platform for future reference to the recordings and also the speaker pack. Any Q&As that you want to kind of register, we'll have a Q&A session at the end of each of the speakers' elements. You can also pop it into the chat as well, and we'll make sure that any questions are asked and answered either in the session or, depending on the volume, we might pick those up outside. The DELS bit is less relevant. We're going to have 3 action learning sets later on this afternoon, 3 breakout sessions split into your ICS footprints. You'll automatically get assigned into those, and we'll work with you as we move through those. So you should hopefully, it should happen beautifully and magically with with Dawn, who is our Teams guru, to take us through that journey. Okie dokie. So
can I just back up on that, Susie, on the end section, those learning sets, those set approach. They really are such an important thing to gradually bring about change and begin to discuss the issues that we're hearing with our colleagues. So I strongly recommend that you could look at those, because we're going to continue them forward. They're going to be rolling. The same people are going to be beginning to turn up. And from my 18 years experience around the CLN, it's that drives the change. So, you know, please, you know, engage with it if you've got the time. Hopefully you have, because it is tremendously powerful and very useful for ourselves as individuals.
I shall bring up the Menti now. So hopefully, if you'll all have access either to a smartphone or to your laptop, there is, if you go to www.menti.com and enter the code 73853105, or use some magical wizardry of the QR code, you can scan that onto your phone, and fingers crossed, that should take you directly there. Oh, look at those thumbs up coming through. That's fabulous. So just gonna, what's exactly a whiz on this yet? Oh, there we go. Right. Okay. So the first Menti for today, if you could pre-text, what do you want to get out of today's session? So it could be some personal learning, it could be some network, it could be any of those things. But what would you hope from the agenda and from booking on today? What do you really want to get out? So if you could just start populating some answers on there, we should hopefully start getting a bit of a live feed when we get those through. So I'll leave you all for a minute or two to just start putting some answers on that. Let me know if anyone has any issues at all with accessing the Menti. If you do, please just pop it in the chat and we can add those in for you. Networking and understanding the forum better. Thank you, really helpful. That's great. How we can work best together to address healthcare inequalities, learn from the experience of other team leaders. Fantastic. Great. So we're going to be using Menti quite a few times during the course of this afternoon, and the reason behind this is this should normally we'd be doing this face to face and we'd be having lots of interaction, lots of opportunities to share our individual perspectives. So if you haven't used Menti before and you're struggling, drop me a personal note and I'll try and work that through with you. Otherwise, it's just really helpful. So this is great. Thank you so much. So key insights into the practical steps to make integrated ways of working a success, learning from others, personal learning and understanding, to get the most out of the service using all available resources, a really, really important thing and really challenging at the moment. Building awareness and discovering new ideas to begin reducing health inequalities. Fantastic. This is really helpful. What I'll do, I'll keep it open for a couple more minutes for you to do. In the meanwhile, I'll hand back to Andy to introduce our first speaker of today. Andy. You're on mute, Andy.
You're on mute.
Beg your pardon. That's the most common thing for 2022, and it will be for 2023, I suspect. Yeah, I was just saying, I think my Menti's really fantastic. That kind of product, to be able to get that real live information coming through is fabulous. Can I introduce our first speaker? Sarah James, who's here. Sarah has a long career in public sort of health and well-being sector. She works across local authorities and has worked in NHS providers. She has a passion for working across the board to deliver whole-scale change and better public service, which has most recently culminated her latest role as integrated place leader for Central and West Lancashire as part of Lancashire and South Cumbria ICB. I think we're really looking forward to hearing what Sarah has to say, and also, you know, when we move on to talk about things like the cardiovascular disease stuff, I know from the stats that I looked at when we were setting this session up, the Northwest and its morbidity around vascular diseases is really high in the country. So it's meaningful for Sarah, I would imagine, just as much as it is for all of us to some degree. And for me, it's an exemplar, because it doesn't matter whether you're in midwifery or whether you're in mental health, whatever you're on. I'm hoping that the elements of what we pick will ring resonance in your mind to what kind of things are relevant to your working place as well. Sarah, welcome and thank you for joining us today.
Thank you, Andy, and good afternoon, everyone. I'm really, really pleased to be here. So I'm going to spend a little bit of time this afternoon just talking to you about some of my experiences in Lancashire and some of the work we're currently doing in Central and West, which, if you don't know it, is Preston and the market towns of Chorley and South Wirral and the areas within West Lancashire as well. So I'm just going to share some slides. So if you can just let me know when they pop up. Can colleagues see those? Yeah, brilliant. Thank you, Susie. So The first thing I want to do before I go into some of our experiences in Lancashire is talk about integration from a completely different perspective. So, I understand from the great bit of welcome we've had so far and the introductions today that some of the people on this call will clearly have seen integration happen across acute and community services, working with primary care colleagues. I wanted to look at it from the other end of the spectrum, and just to share a very brief case study of somewhere that I did in a district council in Lancashire about 10 years or so ago. We had in our area a kind of really small rural population who really struggled with a lot of the symptoms of reduced health inequalities, so real issues in terms of, say, cardiovascular disease, issues in terms of frailty, issues in terms of people appearing numbers and numbers of time to different levels of services. And actually, one of the principles that we took to support those residents, and in this frame I will kind of call them residents, was actually to say, how can we support them in their own homes in a way that is really non-clinical? And we started from the basis of, let's look at the people before they start hitting our services. And we started with a kind of data set that some of you may well not be aware of, some of you may well be, which is an assisted bin list. So each district council has a group of residents who need help putting their bins out. Nothing more, nothing less. It basically means that the binman, when they come to collect their bins, will come and help them. We started with that group of people in one small village and went with, actually, if we know these people need a bit of support, what other support could we wrap around them to ensure that we are supporting them right at that early stage? So we started with this small group of individuals and residents on the assisted bin list and wrapped around them, as it says on the slide, a Meals on Wheels service. This wasn't just a food delivery service. This was people coming in to support with benefit checks. It was befriending. It brought in services from our community services. It brought in services from our voluntary community and faith sector. It then spun off and created groups of residents going for a meal together in a pub and reducing social isolation. What this became was not a textbook integrated service to reduce health inequalities, but more of a group of organisations and community-based people coming together to support a really specific need of residents. That was well over 10 years ago, and that service, with all its interconnectivities, is still going strong, despite, I think it's fair to say, the context that we all find ourselves in and the financial constraints that we all find ourselves in. And one of my rationales for sharing that story with you right at the beginning is to say that actually I think integration and the integration of services does not always need to be as clear cut as what we see as one pathway leading to another pathway to reducing handovers. Actually, some of this is around starting with something as simple as a patient or resident and their needs, such as an assisted bin list, and wrapping those services around them. So just wanted to share that as a kind of start point. Very briefly, so my role, I work in, I said, Central Lancs, and I've given you the kind of geography. I've worked across the NHS in some provider organisations, and I've worked in local government as well. And my current role is really starting to bring a lot of that together at a leadership level across our patch as part of the Wirral, Lancashire and South Cumbria patch. In terms of what I want to share with you today, I'm just going to share some of my thoughts and ideas around some of what I've seen in terms of what integration is, what it can be, some barriers, some opportunities, and then some brief experiences to bring some of it to life. So this particular slide I quite like, because actually I think all too often, and I'm, I've the word integration in my job title, we can talk about, yeah, well, we're doing this for integration, we're doing it for integration. Actually, integration itself should not be the end of what we're trying to do. Rather, what we should be looking at is how we can improve health and care outcomes, and integration invariably leads to that. So actually people will have talked about and will have understandably had lots of work around how everyone sees the right care in the right place at the right time. Actually, that's all that integration is, really. And for our populations and our residents, we often say they think we're doing some of this anyway. They think we are joined up and they think we should be in these places. But I think that's just quite a good expression of what integration is and perhaps what it isn't. In terms of some of the things that integration and the difference it could make, some of the opportunities around it, I suppose, these are some of the things that, people have talked about nationally that we know it has the ability to do. So we know that if we have really well integrated services across our delivery of care, it can help ensuring that people are connected between different services in the most appropriate way, that people have access over information. We know that it is delivered by I think that there's a phrase here about kind of a really confident multidisciplinary workforce. We've heard about integrated neighbourhood teams. We know some of the opportunities that come about that enable people to really connect better to the variety of different services that they are working within. And quite a useful kind of reference point really in terms of the different types of integration. Some of the ways that we've seen it, certainly across Lancashire, is this slide, which is from the King's Fund. And what it talks about is the different levels and different types of organisation. So if I was just to pick up on some of those that we've had perhaps in our area at the moment. So kind of starting with the organisational integration, obviously really formal aspects of integration where organisations are brought together for a specific purpose to enable people to connect. Often, and I think, you know, I work as part of the adult social care leadership team at the county council as well as part of the NHS, and the lead social worker there said to me, that's really an end resort. We shouldn't end up having to merge organisations to get true integration between a workforce. There are other things that we can do for the resident or the patient that we can do ourselves as leaders and as people within the workforce. Functional integration is really talking about some of the kind of the back office stuff. So things that we've done in Lancashire, and we're looking at how we can combine some of our data sets. On one hand, it's quite a simple thing. On the other hand, if we've got a really shared version of the truth about what's happening with our residents, with our populations, with our patients, we can act on that together in a seamless way. So bringing together some of that business intelligence capacity can really help. We've also got some programmes of work around connectivity of back office functions to support our workforce, HR, finance to support primary care as well as supporting the acute trust and other people. Service integration is probably the bit that I think, you know, there will be lots of experience of around the table, you know, around that. How do we create those multidisciplinary teams? And certainly a big piece of work for us in Lancashire at the moment is that development of integrated neighbourhood teams. So groups of clinical staff connected not just to each other, but to the wider communities and making the most of the strengths-based areas that they work within. You know, so how do we connect our clinical teams to the voluntary community and faith sector services within their area? The Meals on Wheels services, for example, the district council have that assisted bin list. Clinical integration, obviously where we're looking at a way in which we ensure that those patients have that clear, seamless access to services and pathways. And then there are a couple that are kind of a bit more lighter touch. So one here that I'd not come across until I started doing some research for presenting these, which was normative integration, where it's really about an ethos of working together. In some ways, it's some of the hardest one, I think, actually, because you're really trying to create a culture and an environment for integration. And that's enabling that trust and commitment to working together to probably enable some of the other areas. Turning to some of our experiences in Lancashire, I just wanted to share a little bit of context in terms of some of our geography, appreciating some of you will be from the area, and I can certainly see a couple of familiar names and a couple from the trust, which is brilliant to see. But just for those of you who may not be as aware of the area of Lancashire and the way that we're working at the moment. So the Lancashire and South Cumbria Integrated Care System has within it now 4 big place-based partnerships. Blackburn, Blackpool, Lancashire and South Cumbria. And if you can see the slides, probably the biggest thing that hits you is the size of Lancashire in comparison to the size of South Cumbria. And our population is around 1.2 million, which is really big for a place-based partnership. It's bigger than some integrated care boards, some integrated care systems. The reason I bring this up and the reason I think it's interesting is the rationale for having such a large place and such a large place-based partnership is to enable integration. So it's to enable really deep integration between the NHS and social care. Our social care is provided by Lancashire County Council, who operate on that level, working in a 2-tier system with their district councils working with them. And we've reorganised ourselves so that we can have that integration between health and social care. It doesn't fit neatly, you know, and I think I acknowledge this, and I've literally just come off a call with some of our GPs talking about, actually, this is great for considering how you work across clinical staff and social care. How does that help with some of our acute providers who actually face other directions, work in some of the other areas? I work in West Lancashire, where we have an acute provider based in another ICB altogether in another patch. Either which way, the geography is never going to be perfect. But actually, one of the reasons for showing that is that some of the impetus behind our changes has been to strive for that integration. And with that in mind, we've invested in our area in leadership for integration, really starting with the highest level. So the changes that were made recently to the NHS, which I'm sure many of you will be aware that created integrated care boards, the guidance talks about having a single person accountable for shared outcomes who leads a place-based governance arrangement and almost is responsible for the integration agenda in your patch. So I think what this really signals for me is that high level commitment to say we want to do integration, we want to make somebody responsible for it. Actually, we need to then devolve responsibility and accountability to the communities that they work with and the partners they work with to do that. So within that, we have our Director of Health and Care Integration, who's Louise Taylor, who holds that joint responsibility for social work as well. And actually, the thing that we now need to do as a leadership team, now that we have this in place, is think, actually, what does leadership look like for all levels of our organisation, for all services that we provide? And we started to construct a bit of a sense of what it would look like for our communities and for professionals, no matter where they work. And I'll just spend a couple of minutes talking through this, and then I will just pause for any questions. So this is our sense of what integration means, or what we're striving to have as an outcome of integration, if I take my own learning from the second slide, for all of Lancashire and South Cumbria. So we've adopted this from Lancashire to Blackpool to Blackburn and across, and they're in the process of finalising it. But I wanted to share it today just to kind of give a sense of, if our partners, agencies, organisations, and ultimately our communities and our residents themselves wanted to work with us, what would it look and feel like? And it goes right from that health creation, which is where we are ensuring that we're working with our communities, with partners in communities, so that they can keep themselves healthy, so that we can have the right campaigns, so we can find the right support to create the right health, so that people have a job that makes them feel valued, that gives them the ability to go out there and do what they want to do, to spend time with their families. Then within that, where there is a kind of universal prevention offer, and obviously that kind of universal service provision will be from a range of partners working together to reduce inequalities. So it will include, for us, services from our district councils, from our voluntary community and faith sector, from our community providers, our mental health providers, our primary care, all elements of our primary care. And also our acute sector as well, working hand in hand with us out in communities. Building on from that, when people need some care, how can we anticipate that? How can we use population health data through our primary care networks, through our clinical and care professionals working together in integrated neighbourhood teams to support our residents out there? How can we look at what the data is showing us? And I referenced earlier on, that was one of our functional integration points, to say, actually, we really do need to do some work on suicide prevention in a certain part of Lancashire. Actually, we really need to do some work on homelessness in Preston. And actually, for me, this is really localised. So as I talk about our 1.2 million in our places, we want to be working with our communities right down at the neighbourhood level and understanding that data and what that means to them, so that we can coordinate that care with them and around them and with a range of partners. And then finally, where people do need care, how can we provide that together in a way in which we can support them to remain at home? And this is where we're getting some really good advantages of having the integration with social care. So actually, how can we working together with Lancashire County Council Adult Social Care, our primary care clinicians, our nursing homes, our hospital at home, our hospices to some extent. You know, there will be partners I've missed, I'm not trying to reel them all off, but actually, how can we all come together to ensure that that care that is provided in a holistic and seamless way for those patients, for those residents at home, and that there is continuity of care there for patients, residents and their families. And then finally, making sure that we've got really good urgent episodic care where it's required, and that we've got that emphasis on step up and step down. And again, different teams there to our urgent care response teams, coordinated and developed by different partners working together within the communities. And my rationale for showing this and talking through some of this is really just to give an example in terms of those kind of theoretical examples of integration, of things that we want to look for at every stage of the process of which people might need health and care support, from health creation right to community-based short-term crisis intervention. What I've not gone on to talk about though is obviously the ongoing intervention and integration services that will be needed when people do need care. You know, when they need elective care, when they're in hospital for planned care, or for urgent and emergency care as well. But obviously you could take that on and forth and carry on with that. So to conclude then, and I put some further links in here just so colleagues can go off and have a look at these if they want to in terms of some of those detailed ones. And I'd really recommend the community powered NHS. So the work that New Local have done, if colleagues haven't seen it, which really just starts to tip the edge of what we think about how our communities can be involved and how much they can do in terms of taking care of their own care and helping to support the different services around them. Really good example there. So just to kind of some final thoughts from me, and hopefully I'm thereabouts on time and happy to take any questions. When thinking about integration for us in Lancashire, I think probably there's three things that are really important. The first is it's absolutely, the integration itself is not what we're aiming for. What we're aiming for is those seamless support and pathways for residents and families. And that's everything from how we develop our family hubs right up until our clinical pathways. I think the second thing is it's at all levels in organisations. So whilst we're very much trying to create the infrastructure, the leadership, the support for organisations to work together, the bringing together of services on the ground does not happen by me or by my other colleagues. It really happens with social workers, working with GPs, working with our community services. And we need to support and enable our workforce to do that. And then I think the final thing is that actually some of this requires really different culture and attitudes and passion to do some of it, which absolutely will come from the people in this room, the people on this call, and is there in people. And I think people have wanted to do this from a long time. And actually, when you see some of the best examples of integration, I'm sure you've all heard about Mark Spencer in Fleetwood, not my part of Lancashire, but we'll take him. You know, absolutely, that comes from the sheer passion. People want to do the right things. And actually all that takes is a bit of energy and enthusiasm to get things going. So I'll pause there, but happy to take any questions.
That was fabulous, Sarah. Thank you very much. Really interesting. And thanks, Susie, for putting those links in the chat. Questions, people can raise hands. We can put stuff in the chat. And see what what's coming forward in your thoughts about what Sarah said, or anything you want to challenge her on or talk to her about that is beyond that. And obviously, if we get too many, we'll still keep these questions and feed them through to Sarah. So hopefully we can get some feedback for you. Does anybody want to start the ball rolling with any questions? Okay, Susie.
Thank you. I'll start the ball rolling if that's okay. So I think thanks Sarah. It was really interesting, and I love the work that you guys are doing up in Lancashire and South Cumbria. I think it's a really great approach, and it's mirrored quite in different ways, but very similar across the rest of the Northwest. Given the incredible pressures and demand at the moment across health and care, and the growing expectations of our populations around receiving that seamless care, and obviously from the government as well, what would your advice be to colleagues on the call today and to our wider members across the CLN in terms of how they can identify and prioritise ways to collaborate and integrate?
Thanks, Susie. And actually the question really resonates with me. So I think I alluded to, I've just come off a call with one group of our GPs talking about how we start to progress this, and you can almost see them looking around going, but there's so much to do and we haven't got time, and how can we do this on top of everything else? And actually a really practical thing that we've just talked about is, I think, two things. You know, one of them said some of this, the right people to connect with exists out there. You know, so whilst there are changes going on all around us, actually the people that we need to work with out there are out there and have been there for years. They're the organisations that don't move. They're the people that we've worked with, the connections that we have at the district council, the connections that we have at Age UK Lancashire, for example, and those kind of things. So I think there's something about actually starting small with the people that you know who are energetic and enthusiastic about making a change. I think if we start to see the pursuit of integration as the be all and end all, we can almost get lost in it. And actually people do not have the time, given the as you kind of quite rightly said, the demands on everybody's time, they do not have the time to go out there and do that. So as I've just kind of said to my group of GPs, let's start small with the people we know, with the changes that you know, and actually use people like me to help break down some of those barriers to do that and move that forward. And if some of those barriers are not knowing the right person, that's one we can get rid of. If they're more fundamental, let's work on that together. So reach out to who you know and what you know, and start small will probably be some of my practical advice.
Thank you.
I'm on mute. I keep forgetting I'm on mute. Thanks, Sarah. Jane Manaf from Warrington and Holden Teaching, I don't know whether you noticed in the chat, slightly similar, but a bit more specific. What were the challenges that you faced, Sarah, in devolving the integration?
Oh gosh, I could talk for a long time about challenges. I suppose some of this is in terms of some of our organisations and then wanting to work together, they will invariably come with different perspectives. And actually, I think probably some of the things that we've faced in the past has been understanding and recognising where different organisations are coming from, some of the competing demands and pressures on their time, and how we manage to find that common ground to collaborate on and do the integration on. I think in terms of how we then devolve that down to a lower level in communities, that is difficult. And I acknowledge it's difficult in a place like Lancashire, which is big, which is really big from a place-based partnership. I think some of the things that have helped us of late has been the kind of real approach and commitment to population health. You know, so that understanding and working with the data in the communities and working from that point upwards has really, really helped in harnessing those voices. So I think probably the challenge is different perspectives, finding a common ground for partnerships, and then the devolvement down to communities has been about really embracing the power and the energy and the population health approach and the public health approach and driving that upwards to work with colleagues.
Yeah, and of course it's an evolving piece, isn't it? Because, you know, we all know that within the system across health and social care, there's a lot of power play that goes on. There's a lot of organisational positioning because of a variety of reasons. So handling that down in a constructive way, it must be a challenge. It must be a real challenge, but yet so essential. Tom Houston has got a question. I'll just take this one. How can the single accountable person best work across the and interact with the boards and other leadership fora as a member at a member organisation? How can they do it? How do they engage?
I think it's a great question. And it's really difficult, and it can't be a single person, I think is probably my response. So the way in which, and actually if I had to pick something, so obviously as I've mentioned, I work with Louise Taylor, who's our Director of Health and Care Integration for Lancashire and South Cumbria. And actually some of the things that we start to talk about is really about relationships. So actually for them to be able to be effective, work across a variety of different organisations, that relies on building trust, relies on building the right relationships, it relies on that understanding. I think the other thing that we need to do and create, because obviously, as I said, that's really difficult for it to have in a single person, is a board for them to work with. So a group of representatives who can work with that accountable person to say, actually, yeah, from our perspective, from this perspective, we think this is the right thing to do. From our perspective, we want to work on this. How do we do that? So while they need to have the right relationships with organisations, we also need to support them with the right governance and infrastructure to enable them to meet those accountabilities and responsibilities and integrations.
Thank you. That's really helpful. Okay, Susie, I've slipped by 4 minutes. I apologise. Can we now use Menti again to try and get some things out from after Sarah's just spoken? And obviously, Sarah, this might be great for you to see what pops up.
Yeah, no problem. So again, if you don't mind going back onto that Menti, I'll pop the code back in the chat again if you've come away from it. So it'd be really helpful, and we won't keep the screen up for too long, but it'd be really helpful to kind of get an understanding from you, just thinking about your own personal organisation, your own personal services. What relationships opportunities can you personally explore to improve the experience and outcomes of your patients, clients? So if you could just have a little think about that, just pop some ideas. What we're trying to get from you, I suppose, from this question is taking everything you've heard from Sarah and her experiences. How do you think you can practically apply that in your day job? What are the opportunities there for those relationships? So if you don't mind, we'll just see a couple pop up, and then I'll close the screen down and I'll hand back to Andy. So hopefully everyone's okay. Oh, thank you for whoever put that one in. Really appreciate it. Just Andy, just while we're just seeing a few more come up, there's just a final question in that we'll take offline for Sarah. So Sarah, we'll link in with you afterwards, and we'll get a formal response so we can share that with David.
Yeah, David, that is thank you, Susan. That is a cracking question, David, and you know, about the systems, the data, the commonality of records, which everybody's been trying to work towards, and from what I've known around the country, talking to various ICBs and footprints and things, it varies at levels of sophistication, but there's no doubt about it. The data issue and the availability of data through the IT products is critical and key to improved integration and communication. And I've heard that from our National Congress in 2020 and heard it continuously since. And it is a different pace in different parts of the country, but I think virtually everybody recognises how important it is. One for Raj Kumar, that actually. I know Raj had to nip off for a while, but I think that's one we need to reflect to Raj Kumar, who was working at NHS Digital, now NHSE under Tim Ferriss, around the data and informatics side. And I'd be interested to see how he responds to that question. Anything else on Menti there that I need to say before we move on?
Just a massive thank you for those of you that have responded so far. I'll keep this open during the next session, but there's some really good stuff in here around working across community and voluntary sector groups, which are really important. How you work across primary, secondary and social care. There's some examples here that we've got for Bolton. So just thank you to everyone. Again, this is really helpful data for us to review and analyse, and we will share this as part of the reporting process at the end.
Yeah. For those people that didn't come to the previous one, we create a report at the end of this session and distribute it to you and to other people that couldn't come, to the ICB boards, things like that, and the region, so that people can see the noises and messages that you're giving and the questions that you're asking, so that they get that wealth of ground root opinion back again, which is so important. Thanks for that, everybody, and thank you very much, Sarah, for joining us. You know, you're welcome to stay, obviously, if you have time, but I understand if you have to dash off. I'd like to move on to our second speaker now. We've just been talking, obviously, about place and some of those complexities and some of those opportunities that are around that as ICBs and the whole system of place and neighbourhoods roll out, working with existing providers in whether it be community or acute or mental health or whichever group that you're talking about, and of course the voluntary sector and care. So a complex mix that Sarah's talking about. But now I want to drill down into a disease area, something that a morbidity, probably an area is better describing it as, an area where a large number of people in the northwest of England have a significant morbidity around cardiovascular or vascular diseases generally. And we have high morbidity, high death rates, as we know, in this region. So it's really a hot subject. It also spills into the emergency care problems that we have. It fuels all that. It fuels a lot of interaction in secondary care and in tertiary care, as well as a great workload in primary care and community. So it is a big piece. And I want to grab an opportunity to ask Dr. Joe Mills to give us his view. Now, Joe is a dedicated general cardiologist with a special interest in coronary heart disease prevention, assessment and treatment, and risk assessment, which is really important. He's been awarded a Cambridge University prize for his doctorate of medicine thesis. He is a consultant interventional cardiologist at Liverpool Heart and Chest, the cardiac lead for Cheshire and Merseyside Cardiac Network, and the cardiac lead for Wirral Community CVD Services, and the UK CVD Prevention Coordinator for the British Cardiovascular Society as part of the European Society for Cardiology. Now, that's pretty impressive, that lot, Joe. And, you know, you're the man that having spoken to you a few times, I think sees opportunities that integrated care and the wider determinants of cardiac health are important and may help you challenge and deal with some of the morbidity and mortality that you're fighting with in your day-to-day life as your job. So I welcome Joe.
Thanks, Andy. Can you hear me okay?
Perfect, that's great.
Unfortunately, I might have a list of accolades, but I can't get my video to work. So I hope you can see my front screen of my presentation.
Perfect. Thanks, Joe.
Okay, that's great. So if you can hear me and see the presentation, you really don't want to see my ugly face. So that's fine. I do apologize. My video has just gone AWOL, but thanks for the kind introduction, Andy, and thanks to Susie and the team for their help in putting this all together and for the invitation today. I'm grateful to all the attendees for their support of this. So kind of to follow on from Sarah's talk, this is going to be a bit more specific about cardiovascular disease, as Andy mentioned, and a real issue for all of us in the Northwest, the Northeast, Scotland, and various parts of the UK, which are real hotspots for cardiovascular disease. So I'm just going to cover 4 elements briefly, and then time for questions. So first of all, what is the need for integrated care within CVD? What would that look like in terms of an ideal? Some examples that I've been involved in 2 particular areas within Cheshire and Merseyside, and then also just to look with you at the planning guidance that came down from NHS England towards the end of last year, an early Christmas present for ICBs and networks to see what we should all be working towards. So just to start off, this is not anything new to most of you. Cardiovascular is a big deal. You can see that this is a very much a polyvascular condition in terms of it often affects multiple organs, and events in one particular area lead to increased risk of further events in that place and others. And you can see that this also coalesces with chronic kidney disease, diabetes, which massively increases the risk of cardiovascular events. And I could put other conditions on here, COPD, obstructive sleep apnea, atrial fibrillation, to name but a few. And these patients genuinely have multi-morbidity. It's very rare to see patients with a single disease condition. And therefore, if ever there were a patient group or a condition or group of conditions that lent itself to seamless integrated care, then it would be this. I just wanted to show you this just because I think it's fascinating. I'm a beneficiary of this. I do valve and PCI interventions in a tertiary centre. But obviously, in terms of the reduction in cardiovascular mortality we've seen since Margaret Thatcher was Prime Minister, and yes, we have seen reduction in cardiovascular mortality for the last 25 years or so, it's not been due to the huge amounts of funding that's been ploughed into secondary and tertiary care centres with cath labs and expensive interventional cardiologists and the kit that they like to play with. It has been more population or preventive strategies looking at therapies for cholesterol lowering, heart failure treatment, secondary prevention, which includes cardiac rehab, and a population fall in blood pressure with more attention to hypertension management has probably been the biggest single factor that's reduced cardiovascular disease mortality. And whilst we spend around 8 billion in the UK across the NHS on CVD, we spend an absolute fraction of that on CVD prevention. And yet that's where the biggest bang for our buck, if you like, takes place. So why do we need to change? Well, if anything, COVID-19 just really reinforced all these messages. We do have such variation in care. You've probably heard the phrase that CVD is just COVID-19 without the virus. And that's a pretty apt description, really. And COVID-19 just further amplified the difficulties we've got with CVD management and the imbalance we have and the inequity in terms of prevention and treatment pathways. Workforce-wise, we know that there's real challenges, and we only have to look around what's going on right now, and that's you know, in addition to all the demands that COVID-19 placed on the workforce. So those are really big factors. We've got health inequalities, as I've already said, and we know that where there's the highest deprivation indices, we see worst outcomes from CVD and a coalescing of the CVD risk factors. So there's a lot of issues and challenges in terms of the background, but we do have, I think, as Sarah mentioned, some perhaps hopeful changes. And in terms of legislative, then ICBs, these boards that are both caring and integrated, and a kind of expectation that collaboration will come from that. In fact, I think that collaboration is now almost enforced through provider collaboratives, which we're starting to see take place in our area, and which I think have got real positive benefits, again, as Sarah described in some of her slides. Just mentioning deprivation and looking at that within Manchester and Cheshire and Mersey. These are some ways of measuring deprivation, but you can see this is the Metropolitan Borough of Manchester. It looks that it is deprived compared to England almost in its entirety. But if you look just in comparison within the Manchester deciles, you can see there are areas of worse and less deprivation if you just judge it by Manchester standards. And this might be helpful when ICBs or PCNs or places are looking to target new ways of working and integrated care. Within Cheshire and Mersey, we have the same issue. So this is the darkest blue areas are the most deprived areas. So this is Liverpool, Knowsley, St Helens and Sefton. So we have the same problems in Cheshire and Mersey just across the way. If you look at, interestingly, prevalence of coronary heart disease and heart failure, they don't coalesce so completely with the most deprived areas. And that we could discuss why that might be. But again, it's back to data, as I think we've just been talking about, maybe coding within primary care, but also the demographic of those populations. But what's I think really important is this, and this is very starkly coalesces with the most deprived areas in terms of coronary heart disease admissions, heart failure admissions, and overall heart disease mortality, particularly premature mortality, absolutely fits with those most deprived areas. And just not to leave Manchester out of this, this is the top 10 worst performing areas in terms of coronary heart disease admissions to hospital. And whilst there are 2 northeast boroughs within this list, 8 of them I think are from Cheshire, Merseyside and Greater Manchester, and you can see Salford in red there. I don't know why I picked Salford to highlight. Okay, so how do we deliver integrated care across CVD? Well, this is a kind of how it might look. This is a best practice guide, if you like. So within primary care networks or within GP community-based part of the pathway, then what could we put in place to help with this? So we need CVD expertise, and that's something we're trying to develop within the network so that each PCN has somebody with CVD expertise to liaise with and work with. But can we use other elements and workforces within that area to help deliver our strategy? So physician associates, clinical pharmacists, practice nurses are all part of that jigsaw. Using technology as well to have better access to consultant cardiologists. Some of you will be aware of a facility called Consultant Connect, which some areas use. But can we expand on that? Can we bring more of our primary care colleagues into our MDT discussions to support decision making? In the middle is more community-based services, so a sort of a transition between the primary care and secondary care. And what services would we want to deliver within there? So you can see cardiac rehabilitation, heart failure and diagnostics. So community diagnostic centres would very much fit within this pathway. And then to the right is really how we oversee our secondary and tertiary care services so that they coalesce and fit within the other elements of the pathway. And that's where our cardiac networks come in, and GIRFT, getting it right first time, which is really an important framework which we should use to oversee all of this. And we can discuss that at the end if needs be. This is a very busy slide, and I apologise for this. This kind of concept of a cardiac collaborative was formulated by my colleague John Devlin at Heart and Chest, and I think it's a really nice way of breaking down integrated care for cardiovascular disease, because it can be quite overwhelming. But if we break this down into services, strategies or interventions relative to where people live, and looking at this in this particular slide, time in minutes away from where people live, you can get an idea of how these services or strategies or facilities might sit and where we can build our interventions. On the left, there's a description of how the collaborative will interface with the ICS and how it will oversee or orchestrate this process. But the delivery, as you can see, is quite complex. If you look at this in a different way, you can see the various elements that happen within each of these places. So within the self-care part of the Venn diagram, health coaches, social prescribing, pharmacy input. Within primary and community care, we've got integrated teams working between hospitals and community, prevention and risk stratification. And then we've got secondary and tertiary care services. But you can see there's a real connectivity between all of these. And that, I think, has to underpin genuine integrated care within CVD. And it's interesting how activities are going on without our knowledge, or certainly without those of us that are involved in delivering cardiovascular disease care. So this is an example of the Housing Association, and they offer health and wellbeing officers interventions to their clients as a matter of routine. And you can see some descriptors there of the kind of interventions based on exercise, nutrition, gym type activities, and also, and very interestingly, getting volunteers together to look at their local area and to identify what the challenges and inequalities are that they're seeing with their own eyes, and to report them back, and then to escalate those to try and overcome them. So this must be part of our integrated process. And if you look on the right, there's a number of other stakeholders. Some NHS, so we have CHAMPS in the Northwest in Cheshire and Mersey, that's our public health arm, who are very, very engaged within both the network and with our primary care colleagues in terms of CVD prevention. But there are other agencies with which we need to work in order to make sure that they're generally part of the equation. So I wanted to just quickly give an idea of a couple of examples that I've been involved in where there is a degree of integration. And I wouldn't say for 1 minute this is the full panacea of integrated care, but this is Knowsley, which was one of those red blobs on my diagrams of one of the most deprived areas with very high rates of hospital admission for heart disease and heart failure. So the aim of our integrated care model was to increase quality, reduce fragmentation, reduce inequality, and move care closer to home, whilst also increasing productivity and therefore efficiency. And I think we'd all agree that that's probably some of the core tenets of integrated care. And I think we were very pleased at how this worked out, and it was through a lot of blood, sweat and tears, as you can imagine. This was the kind of overall profile of the services that were offered throughout the Knowsley community. A lot of these were delivered within large GP practice settings. Everything was delivered outside of a hospital setting, but there was easy access between all of these different strands. So patients weren't moved backwards and forwards, they were moved between services as necessary. There was also engagement with local hospitals, so mainly Wiston Hospital, to facilitate stroke patients leaving hospital early. And that was quite a new feature for a community service. I'm going to come back to cardiac rehab here. So one of the knock-on consequences of this model, and we didn't foresee this at the start, was the merger or integration of our rehabilitation services. So pulmonary and cardiac rehabilitation merged, and stroke rehabilitation came to be a part of this. And we also undertook some pilots for cancer rehabilitation with great success. And it was quickly realised that this was beneficial for staff. They enjoyed the challenge, the training, the career opportunities that this allowed. It increased the flexibility of the offer to patients. And so it was a great success, and is a model that's been looked at nationally in terms of improving access to rehabilitation generally. So, and I just laud our results for 1 second. These are the national data regarding cardiac rehabilitation. And you can see that the bottom line is that 50% of patients who are offered cardiac rehabilitation actually attend. And within our Knowsley service, within 2 years of developing that service, our attendance rates were up to nearly 80%. So a really quite remarkable improvement. I'm going to skip over that for the sake of time and move on to the Wirral service. So Wirral slightly different. They already had a community cardiology service, which a lot of very, very active GPSIs over in Wirral, working within a community hospital setting. Sorry, let me just try and dismiss that if I can. Which I can't. There we go. Apologies. So this was advancing or enhancing the services that were already in existence to try and create a better offer to the patients, and trying to work more closely with their local hospital, Arrow Park, with which there had been very little interaction. So separate services working in tandem, but not in cooperation really. And this model was fleshed out and funded with work from both the CCG that was then and more recently with pharmaceutical support to really build a more holistic integrated service for patients with CVD in general, but heart failure in particular. And if you look at the outcomes in this right graph here, the intervention commenced in full in 1920. And if you look at a comparator CCG area, so St Helens, then whilst they saw admissions for heart failure increase during that year, we saw admissions over in Wirral fall by about 80 patients, so 35 or so per 100,000, which would work out at a saving to the healthcare community of Wirral of around £800,000. And the overall cost to continue this service, even removing the pharmaceutical company input, would be around £450,000 to £500,000. So very much cost saving, as well as much better for patients. I'm not going to go into the details of exactly how it works, but I think it certainly serves to be a principle and proof of principle. And I think, as Sarah was suggesting, that we start these integrated pathways within a relatively small scale, show that they work, get people on board, working differently, and then they can be expanded. So I think there were a number of lessons that were learned from these two slightly different but nevertheless linked integrated care and transformational services. One was certainly to engage with staff at all levels. I think staffing and the workforce really make or break a lot of these ventures. It is always difficult and challenging, and to some degree frightening for staff to be asked to work in very different ways, perhaps under different structures. And that was a big element to this. Trying to make sure that services aren't duplicated, I think, is key, and that's one of the central themes for both services. To get people to be willing to work differently and understanding what the needs were. What's the key aim and ambition of your new integrated service, I think, are all really important facets and lessons. This is my last slide, and I just wanted to draw your attention, if you've not already seen it, to NHSE's NHS objectives for 23-24. This is the planning guidance that was delivered, as I said, as an early Christmas present to ICBs and various networks to look at and try and work out how on earth they're going to try and achieve some of these ideals. In the left-hand panel, there's 8 elements that link to recovering from COVID and improving productivity. In the right-hand panel, there are 4 elements that link specifically to the long-term plan and transformation. And I'm not going to go through all of these, but in terms of my keen area of interest, obviously as a cardiologist, there are elements of this that are very, very important. So within primary care, urgent and emergency care, improving ambulance category 2 responses, primary care, particularly using other workforce, so you'll be aware of the additional roles reimbursement scheme and those individuals and what activity are they being asked to do and what could they do that might be linked to prevention activity. And on the right, there's 2 particular elements that are linked to CVD prevention. Hypertension I've highlighted, and the one underneath is to do with lipid lowering therapy and statin prescription for people with a high CVD risk. That's probably achievable, and you'll see the target there is 60%, and we're actually just at or under that by maybe a fraction of 1 or 2%. But in terms of hypertension, the target by March 2024 is that 77% of patients who are registered as hypertensive on a GP register should be treated to NICE guideline levels, so below 140/90 for an office blood pressure. And at the moment, the average across Cheshire and Mersey, and I suspect the Northwest, is somewhere around 50% or just below. And the rate of improvement for most practices and PCNs is of the order of 0.1 to 0.5% per month. So this means it's going to take an awful long time. We're talking 5, 10, 15 years at the current rate of improvement to hit this 77% target, which we need to hit by March 24. So we can't carry on doing what we're doing. We need to think differently. And you can imagine that is definitely vexing people like myself within networks and colleagues within the ICB to try and understand what we can do. But if ever there was something that might galvanise us to genuinely look at integrating the way that we deliver CVD prevention this is a real stimulus to that, because we have a real visible and tangible target to try and meet. And I think it is achievable, but we have to work incredibly differently to do that. And of course, I think, as Andy mentioned at the beginning, funding is going to be a major issue. But if we want to achieve it, we can, but we need to work slightly differently. So I think you've probably heard enough of my dulcet West Midlands tones for 15 minutes or so. I'm really grateful, as I say, to the opportunity to talk to you all. Thank you for listening, and I'm happy to take any questions. Apologies again that you can't see me.
That was fantastic. Oh, I'm getting feedback. But never mind. What we're going to do now is Susie's going to open Menti up so people can put comments in, whilst Joe, we also take some questions, so that the two things are happening simultaneously, and you'll be able to see them on screen as they come through. Susie.
Thank you. Let me just present this again. Okie dokie, thank you. So the question now is slightly different from the previous one, and thank you for people already starting to put these things in. What successes and or opportunities are there in your own organisation or system for better integrated working? So you might want to talk a little bit around some of the stuff that you're already doing across your areas, or something might have triggered your mind today, thinking actually this is something we could really get a grip on within our organisation or across our system. So you might want to reflect that as well. So if I'll turn this off, it'll still go on in the background, and I'll hand over to Andy for the questions.
Yeah, and the reason I did that, Susie, was because the way you've just spoken, Joe, it fits perfectly with that, to stimulate people's minds, whether that they are involved with the coronary heart cardiovascular disease issues, or whether it's another thing. But it certainly is a challenging thing. Can I'm looking at a look for questions for anybody who puts them in chat, but can I just ask you one, Joe, to start with? You've guided us through a really thought-provoking journey of how integrated care can really optimize the outcomes for people with cardiovascular disease. Can you share with colleagues the important things to consider when they're looking at their own services in their own areas? What would you encourage them to be doing?
Yeah, thanks, Andy. Again, I'm really sorry I can't get my camera to work. It's obviously I've broken the camera with such an ugly face, but there we go. Yeah, I mean, listen, it's challenging, isn't it? And it can be daunting. So I think you need a realistic outcome. What is it that you're trying to achieve? What's the problem? What is it you're trying to fix? Now, is it inequalities or fragmentation of a pathway? Is it that a specific service is inefficient? What is it? What's the output? And I think that's really important to define what the question is that you're trying to answer, or what the problem is you're trying to solve. Because integrated care may not be right for everything in every circumstance. So I think that's the first thing. The second thing, I think, as I mentioned, I think is about workforce and understanding what are the workforce implications of changing the way that you're going to deliver your service, and whether it's merging teams or asking teams to work differently in different settings with different paymasters potentially. That's really critical, and perhaps something that we didn't think about enough, particularly when we took on the community service for Knowsley. That service, there was no community service. Some of those teams were working for other community providers. Many were hospital based, and it was interesting how difficult it was to get the workforce to come along with this journey, positively and happily. You asked them 6 months on, delighted, and everybody was very on board with this. But I think that was something that we learned. And I think the final thing is, and maybe this won't be such an issue now with how ICBs function and how funds should flow, but it is the way that the NHS is financed and the way that your service it attracts its remuneration. How will that be affected? Who are the winners and losers by integrating care? Because there shouldn't be. And that's really important, to make sure that the way that finances flow is commensurate with the change in service. It's not just about making a case for this service to be more efficient, productive, or cost effective. It's, as we all know, there are perverse incentives in the way that NHS funds flow and activity-based care and so forth. Those have to be thought about. So, for example, within the Knowsley service, we were able to secure a block contract for a certain number of years that gave us sort of financial security to take on staff with reasonably lengthy contracts and to deliver the service, an integrated service, in the way that we thought would be best for patients, and using patients to help design that. I suppose that's perhaps the most important element of all of this, is what do the patients think about the current service? There's a big piece of work going on in St Helens at the moment, asking patients about what they feel about the heart failure service locally, and they're going to use that output to then design a better integrated model with the patient at the core of that redesign. So those would be the 4 elements that I'd focus on.
Okay, that is really, really helpful, and I'm sure it resonates to people in their areas and and how that relates for them. There are 3 questions that I've just had popped in. Actually, I've got a 4th one now, but and they kind of, I'm going to match them together for you, Joe. We've got something as practical as, you know, from Francis Sanders about what can we do more about hypertension, which is, you know, the one to deal with actual factual stuff. But then we've got situations in areas where you've got policies and processes where people with high systolic blood pressures above a certain point, 150, are going to EDs, and yet so secondary care pulling those patients in rather than working with primary care in a more constructive way. And then similarly, another disease area like mental health, which, you know, I've worked in as well, high levels with anxiety and depression, who've got quite significant heart disease related problems because of the consequential effects in the way they eat, the way they drink, their weight, their various other things, and their drugs themselves and how they have on them. So I've thrown those all together just so that you can comment on the complexities of that broader thinking. How would you reply to that breadth of comment there?
Yeah, I mean, you know, there's no doubt of the size of the challenge, but if you, I mean, thinking about, I mean, mental health and patients with mental health, I think it's about defining exactly that this is an issue, and the question is a good one. It's rightly raised. Well, what are the interventions that we can employ to make sure that these more difficult to reach or overlook patient groups, you know, fit within the integrated care design that you have? And, you know, there are ways to do that. So, for example, prioritizing patients with mental health or who are coded with mental health disorders, prioritizing them for vascular health checks. And we've considered, should we run that as a service within Heart and Chest? Should we deliver vascular health checks and have a prevention service within a tertiary provider? That's a very kind of unique, different way of thinking about it. But what you would do there is you would prioritize those groups where you know the risks are highest and they are the hardest to reach. And could you do it, run a dedicated prevention service for these particular groups where they don't necessarily access general practice, or the services that they do access are not necessarily suited to provide CVD prevention interventions for them? Alternatively, you could make sure that those services do have appropriate links and skills to make every contact count and provide short interventions, and to know where to refer patients on to if they are concerned. But it's a big challenge, and we don't have the solution to all of this. And hypertension, which links with that, I don't have the solution to that either. All I know is that we have numerous healthcare professionals within the community who would be absolutely keen and are sufficiently skilled to manage hypertension, and who we don't ask to be involved in the pathway. And you mentioned about this sort of trigger reflex of patients being sent to A&E and whatnot, and that really is a breakdown between the link between secondary care and primary care. If there was an effective community cardiology service that these patients could be referred to and seen within 24 or 48 hours, then this would avoid a lot of these unnecessary interactions. And similarly, technology, I mentioned Consultant Connect. We use it in Wirral quite effectively. GPs ring up a dedicated number, they speak to a consultant cardiologist, and they get an answer immediately. And it's a very, very simple system, but why don't we use it across Cheshire and Merseyside or Greater Manchester effectively? I don't know why we don't. It's probably down to funding or proof of concept or whatever. But this type of variation one place using it effectively and other places probably not even knowing anything about this. We need to overcome that.
Yeah, fantastic. You know, we'll show you the chat later. You can have a look. The chat is fantastic here, what's coming through. And the subject matter that we've chosen is a cracking example, isn't it? ICBs and ICSs, the three of us across the Northwest, which most of us here are on this Northwest session. It's a real challenge, and this is a really big volume issue and a resource issue and an emergency care issue. And there's a couple of people that said it's really inspired them to look at how we better collaborate, how we get underneath this in an integrated way, but not only between health, but between health and social care, health and housing, all the things about the wider determinants of health, which, as you said early on, has a bigger impact than some of our intervention stuff. So wonderful. Really, really thank you, Joe, for doing this.
Thanks, Andy. My pleasure.
Susie, can I just bring in the final Menti break before we look at getting into these action learning sets, which I'm hoping some of you guys will get into, because there's a lot to get hold of here, and the facilitators are charged and ready to really help you think in some depth about this.
Thanks, Andy, and thank you, Joe, as well, for a fantastic talk. It was, and the conversation afterwards was really, really incisive. And I do know Andrew Francis has already made a commitment to be inspired to do something more collaborative. So thank you so much for that. So the final session for the Menti, before we go into our breakout sessions, I just want to capture from all of you that are left with us this afternoon what your general feedback is from today's session. So what we use this for is we have another session due on the 3rd of May, which will be looking at the wider partners and collaboratives. So we've spoken a little bit about housing and how the role of housing, but we'll be bringing in the community, voluntary, third sector into the conversation, just to think about those wider collaborative opportunities. But I'd be really interested to hear from you, how you found today's session. Did it inspire you, which I know it's done for some, but was it stuff you already knew? Was it something new you'd heard? Were you surprised that you didn't hear about something that you were expecting to hear about? So just put a little bit of challenge back to us would be really helpful. The other thing I'd like to ask as well is that following the May session, is there anything else that you think would be helpful for us to bring together on your behalf in terms of the wider impact of integration, some of the challenges we've talked about in terms of trying to deliver that, and anything like that? So really, really anything that you can give us. Compliments are fantastic, but critiques and suggestions of how we can do things better is also very, very welcome as well. So thank you. We'll keep this going on in the background, and again we'll share everything that we've got from you today and everything that we've talked about.
Brilliant. Thank you, everybody. This is great. So we're going to break up into groups now. We know who's on the call. Behind the scenes, magically, Dawn has been doing her electronically wizardry, so that you will be going in the second at the touch of a button into a room. The rooms are facilitated. Please stay. There's going to be some questions specific about general reflections on what you've heard today. What does this mean for you in your world and your job? Where does it come right down to you in whatever subject or thought area? And then, like Francis Andrew was saying, what is my personal commitment? Am I going to go and just do something, or go and tap somebody on the shoulder about something? Am I going to play my part? Am I going to go back to ICB people and say, I'm interested in knowing a little bit about this and what you're thinking? So we'd love to get something from you about what you feel you want to do, so that this isn't just a talk at, it's you actually beginning to lead the change and be engaged in the change process. Really important. And believe me, having done this over many years, it snowballs. It gets bigger and more effective. It really does. And people listen and pay attention. So I'd encourage you to get into these sets. They're only going to be for an hour, and just over an hour, sorry, and we're professionally facilitated to help you along. So is there anything else that I need to say, Dawn or Susie, or can we break now into the sessions? Just to get, if possible, I'm going to put the two facilitators on the spot. Just a little bit of a summary of, in your own words, how you found the session and the questions and things like that, just so that we can all hear. So perhaps Tom, could you go first?
Yeah, but by all means, key findings, Andy, or
yeah, just key findings and
yeah.
any themes that you think were impressive to you or that you felt needed to be said.
Yeah, by all means. Yeah. So I think there's key issues or barriers to effective integrated working can be summarized quite neatly probably into two kind of buckets really. So the first of which would be cultural. So cultural in terms of team cultures, legacy of the way teams and individuals, organizations even work, they're being the key barriers to effective integration, I suppose. But we've got a lot. I don't know if you want me to go through these now, but we've got a lot of real concrete
You don't
steps.
have to go through concrete stuff, but just a sort of an overview, really. Yeah,
exactly. So a range of measures, from things like reaching out to individuals to start building relationships, to start building kind of joint ways of working, sharing of insights, working on the idea of using the list, like the bins example that we had in the first presentation today, of working along with a kind of very comparable thing like that with different clinical teams across organizations. So powerful. It doesn't need to be a complicated governance, compliance, tech, budget integration piece. It can just be working with a simple Excel list. That's how these things can start, as long as they're backed up by regular conversations and the relationships. And another key theme that came up as well was making sure that we're tapping into all of the learning, collective wisdom right across the teams, particularly of more junior staff as well, where that staff don't all feel empowered to give their staff suggestions on an ongoing basis. So situations where feedback about how things could be done better, particularly around integration in this case, and then a kind of a continual feedback loop from that feedback will ensure that the pipeline of good ideas keeps on coming. And I think at the moment there's some missed opportunities about capturing that and feeding that back because we're not necessarily responding in the right way. Another kind of great example that we had from our group was about promoting joint agendas across teams and organizations using shared information sources. So we had the example of a digital EPR still being developed in the brand new world at trust level rather than across the ICS footprint. Yet all the noise at the same time was about making sure that we are working in a joined up way. The information sources, the things against which we measure ourselves, are not being produced at the footprint at which we should be working. I suppose they're some of the key themes. I don't know if anybody else in my group wants to pick out anything that I've missed off. There's lots of other great feedback which we've had.
I think it was great, that feedback, Tom. And the thing that I noticed about your group is the sort of the bite-sized chunks that people were setting them tasks on that felt possibly doable, but I know that they would then lead on to other activities and increase in an escalating effect. But the bite-sized chunks was a nice way of doing it. Okay. Anybody who's going to report back on the other group for me? Who was facilitating? Have we got somebody here? I can't see on my screen.
I'm happy to do that, Andy, if that's possible.
Okay.
Susie, if you want to jump in towards the end as well. Yeah, no, to be honest, we had I welcome any thoughts as well from anyone in our group. We had quite a heavily acute focused conversation around a lot of the work that could be kind of increased, a lot of kind of improvement work in the acute kind of sector. So we talked a lot about some of the stuff Tom covered there around engagement with staff at all levels of an acute trust, and that kind of primary care input as well, tertiary community care. A staffing culture being quite a big change that we know everybody at all levels are under ever increasing pressure at the moment, and the idea that change is not easy, change takes time, and the reason for that is often a culture shift, and it's often the requirement of a culture shift across both. We realise that both within the health service but also outside the health service as well, and the demands that kind of is in everyday life at the moment, and the way kind of the life is changing on a seemingly rapid scale at the moment. we talked around kind of what would be useful kind of for kind of future sessions, and around why how maybe kind of working with the CLN, the kind of useful workshops could be developed in the forthcoming months, weeks and years, around kind of disease prevention, and the idea that, you know, a lot of the work that happens in acute, you know, we need to look at kind of preventing, and that kind of public health, stakeholder engagement element of health that we often we talk about, but do we cover it in enough detail? And that not just being on topics that we hear more about, that being, you know, there's a lot about mental health, a lot about CBD, etc. Also about kind of MSK and other topics that we see in a secondary care and an acute kind of profile, but could they potentially be prevented in the long term, and how we kind of measure those, both on, you know, numerical, but also kind of the human aspect of that as well. So some really good thoughts. Some really good commitments that were made as well. I won't go into detail around them as well, but commitments in different pathways in different clinics that cover the group that I shared time with. And yeah, a really good kind of conversation. Happy to summarise and feedback via email.
That's fantastic.
Can I just add as well, and because I sat on both groups, I think the kind of, there's a real passion and there's a real drive to do this sort of thing for the benefit of our population and for our patients. But I think there's a real recognition, and something we as a network need to think about how we support. About people are exhausted and it's difficult and it's challenging, and there's no capacity to do a lot of this extra work at the moment. So where there is a real passion and commitment to do it, and there are opportunities to influence and develop those relationships from some of the conversations I've had, there are some areas where, you know, how do we enable the enthusiastic group of people that really want to do this to flourish and fly and develop these things in a really struggling and difficult environment that we're all finding ourselves in across health and social care. So it's just, I think that's for me is the one thing, you know, but there's lots of passion, there's lots of enthusiasm, there's so much expertise and wisdom and knowledge out there. How do we help people kind of get that space to let that fly and to take it forward in the way they know how to? Yeah,
and I hear that very loud and clear. And you know, the beauty about the NHS CLN is that it's multi-professional care and clinical, and it's got reach to the ground, to the frontline workforce. It's apolitical, it has no axe to grind, but it also has reach to the highest levels of the national, to regional, to boards, and influence CEOs and things. So we have the ability to try and interpret and translate the connections across the system. And sometimes it becomes obvious where there are difficulties that need a little bit of a hand to be unwrapped to get the best effect that all people are trying to get to. So I think you're right, Susie, in our conversations outside in our central team, we can listen to your feedback and try and reflect and respond to the pressures and difficulties you're having, and seeing if we can unlock things or make communications occur, or produce reports that make it clear what's being said. Sometimes that's all that's needed. So we can play our part in that. And I think, Susie, we'll spend our time with the board discussing how we do that. Before I do a little roundup summary, anything from that Menti that you want to talk about? All the Menti feedback, was there anything that you've managed to see? Or, and I know we'll get a fuller report later when it all goes out to everybody, but so anything mainly that you picked up? Susie?
Me? Yeah, I think there's been really positive feedback on our speakers, and we've been really lucky to have such fantastic speakers here today. So thank you for that positive feedback. And again, similar to the first session we had back in November, having that space and that opportunity to think and to network and to hear other people's perspectives just seemed to be quite valuable from today. The feedback, this last slide is still open, so again, there's been lovely stuff put in there, and really appreciate that. But again, if there's anything you think we could do better next time, anything you'd like a bit of a focus on to maybe take the conversation or the thinking forward, do please pop those into our feedback. We're here to learn, we're here to listen to the needs of yourselves. Okay, thanks, Andy.
That's great. And so, I mean, great session. The speakers were fantastic. They certainly inspired me with some of the things that were saying, and took it, you know, the ideas and examples that can be expanded across the whole raft of subject areas for the greater good of the patient, citizen, client, whatever you want to call them, in whichever environment you were actually working in. My comment to one of the groups, and I think they say it to both, is never underestimate the effect of the teams and networks that you're in. Go and talk to them about what you've experienced, talk to them about what you'd like to see happen. It's amazing how that snowballs and begins to open up opportunities and ideas. And as we hear them, we reflect it back to boards, CEOs, across ICBs, trusts, providers, provider collaboratives. So if we're hearing messages, we influence those people directly at that level at the same time. So sometimes the combination of the push and the pull can have a significant effect, more than you'd expect it to. So, you know, be inspired to talk to people about what you feel, what you've heard, what you think. We've got a third session coming up for the Northwest. What was the date of it, Dawn and Susie? I've forgotten the date. I do beg your pardon. Was it 3rd of May? That's the plan, isn't it?
That's
Session
the
for the 3rd of May. We're lining up at the moment, expanding some of the ideas around the voluntary sector, housing, other people, and integrating it into some major issues and magnifying and making it clear how much of an effect they do have, even though within clinical and care we might not fully see it. So we'll do elements of that, and obviously we will consolidate what's happened on these first two with the first two reports and make sure that we interpret that into the third one and to help direct that third one in a way that's moving. And I think now that the ICBs and ICSs in the Northwest are maturing out and beginning to develop, we will be there in a supportive way to offer any kind of help or support that they might want that the CLN could offer for them if they choose to do that. And obviously with the information that you guys bring, that's really powerful, that they see what the grassroots or the middle system or the higher level people on boards are saying in a collective across the patch as well. So we'll be doing a bit of that to see how that takes this whole picture forward. Anybody got anything else they want to say, either that's attended today? Is anything burning that people would like to say before I draw it to a close? No, well, great. Well, thank you everybody for attending. Thanks for everybody that stayed on so late in the afternoon. I really appreciate it. We'll get a good report out to you, and Dawn will be in continuous contact with you about what's happening next. So fantastic. So thank you much. Thank you all indeed.
Thank you, Andy.